I'm here with Barry Lee. Barry, you gave a really nice talk on corneal considerations during cataract surgery. There's a lot of stuff that you covered. You polled the audience. It was very, very interesting. Let's just pick out a couple topics here. Let's say that I have a patient come into the office. Let's say two patients. One of them has got frank keratoconus and has manifest cylinder in spectacles, right? And the question is, do I put in a toric lens, and how much cylinder should I aim to correct for, and where does topography come into planning the astigmatic magnitude of the treatment? To the second patient, same sort of thing, but form fruste keratoconus.
Okay.
How do we manage these?
Sure. I mean, so those are difficult scenarios. I think certainly something we see a lot. I think there's three things I look at, and that's what we will discuss in the talk. Is number one, is there a lot of irregularity in the topography, or is it somewhat still of a regular pattern? Number two, what's the patient's age? If they're fairly older, then you can really figure out their cornea is probably not going to change very much, versus maybe a younger patient with, say, a steroid-induced cataract, where you're going to see more of a topography change with age. And those are two scenarios that we really look at. The third thing is, are they wearing a gas perm contact lens now, or are they wearing glasses? So, we talked about the age scenario, but if someone's in glasses right now with their form fruste keratoconus or mild keratoconus, I really feel like if they were corrected well, then I think it's probably safe to put a toric lens in that case, especially if they're an older patient. But if you have a younger patient wearing gas perm contact lenses, and that's what they get their vision, if you put a toric lens in that patient, they're going to need to get back into a gas perm contact, and that's going to cause lenticular astigmatism. Yeah. So those are patients, if they wear gas perm contacts, you really ought to avoid a toric lens and stick with a monofocal, and then get them back in the gas perms if they need it.
But one of the points you make, a really great point, an obvious point once you say it, is that even for keratoconus patients where some component of the astigmatism is not regular, there is often enough of a component that a toric contact lens can still be of benefit.
Absolutely.
And that a toric contact lenses shouldn't be written off just because someone has keratoconus.
Right. No, that's a great point. Toric lenses still are very useful for a number of those patients, and certainly for the more severe ones, those need to go into maybe a gas perm, but toric lenses are still have a mainstay place for mild keratoconus for sure. And
you're going to warn the patient and have a conversation first. So that was my easy question, Barry. Let me give you one harder now. So let's say that I have someone come into the office with manifest cylinder, with keratometric cylinder. Okay, the Myers look a little bit bumpy. And it's clear that the patient has an anterior basement membrane dystrophy that is contributing to the cylinder. Do I put in a toric lens? Do I not put in a toric lens? Do I do a superficial keratectomy first? What do I do with these people?
Yes, that's another great scenario that we see a lot. In that kind of patient, I would do a superficial keratectomy first, allow the topography to normalize, which it typically will in about 4 to 5 weeks, sometimes 6 weeks. And then once that is stabilized, then you can kind of reevaluate. And if you've taken care of the EBMD fairly well, and they still have a nice regular pattern of astigmatism, I think a toric lens will be fine in that patient. But if in a lot of cases, in my experience, once you do the superficial keratectomy, the cylinder will actually go away, and you end up not needing a toric lens in those cases in many situations. So I think the key is do the superficial keratectomy first, and then reevaluate the topography once the surface is healed, and I think that'll keep you out of trouble in a lot of cases.
Yeah, that's a great point. Basically, do the surgery staged.
Yeah, exactly.
Yeah. Barry, this is really helpful stuff. I'm delighted that you're giving the talk that you're giving. I'm even happier that you're so generous with your time with us today.
It's a pleasure. Always a pleasure to talk with you. Thanks.